Hello everyone. Today's topic is pleural abnormalities. So firstly, I will introduce quickly the anatomy of pleura, but before that I want to say that the pleural cavity is not visible on normal chest X-ray, but only when it has some abnormalities. So firstly, the pleura, it looks like a sac enveloping the lung, and it has two membranous walls, the inner visceral and the outer parietal. And dynamically, this membrane contains mesothelial cells and a deeper layer of connective tissue, which contains vessels, nerves, and lymph. And also this membrane responds actively to adjacent inflammation and to accumulations of fluid within its space, and this previous reaction is called a pleural effusion. Otherwise, if the pleural space is filled with gas or air, then it will be what is known as pneumothorax. So there are four main types of pleural abnormalities, starting with the pleural effusion, which is a collection of fluid in the pleural space, and this fluid it gathers in the lowest part of the chest, and according to the patient's position. So if the patient is in upright or stand position, so the fluid will surround the lung base, forming a meniscus sign, which is a concave line obscuring the costophrenic angle and part or all of the hemidiaphragm. And if the patient is in supine position, then the pleural effusion will not be visible, and it will be so difficult to detect because the effusion which will layer along the posterior aspect of the chest cavity. And then we have the pleural fibrosis or thickening. So the thickening is usually occurs at one of these two sites. First site is at the costophrenic angle as a result of previous pleural infection, where we see the fibrotic blanting of the costophrenic angle, which may be very similar to a small pleural effusion. And in the other side, which is the over the apex of one or both lungs, this maybe happened due to either old lung infection in case of TB or due to compression. This compression, it may be of lung and pleural tissues by small apical bullae. And I want to add also, if the appearance is unilateral, then it can appear identical to a flat apical, which we name as Pancoast carcinoma. Then pleural plaques. So the plaques are focal areas of thickening of parietal pleura due to previous exposure to asbestos. So these pleural plaques, they are most commonly seen posteriorly and laterally, and they are predominantly affecting the lower third of the thorax. And they do not involve the costophrenic angle. Sometimes they are calcified, and they are irregular, well defined, and classically say they look like holly leaves. And the last type is pneumothorax, where we said before it's air trapped in the pleural space, which may occur spontaneously or as a result of underlying lung disease, but most commonly it's caused by trauma with laceration of the visceral pleura by a fractured rib. So if the lung edge measures more than 2 centimeters from the inner chest wall at the level of the hilum, it is said to be large pneumothorax. And if there is tracheal or mediastinal shift away from the pneumothorax, then this pneumothorax is said to be under tension. And here we're gonna move to cases. So we're gonna start with discussion of the first case, where we see an extensive unilateral pleural thickening due to calcification. And as we said, in such cases, patients have previous TB. Then the second case, we see thickening of some areas of the parietal pleura, which is covering the domes of the diaphragm. And we see some plaques which looks like a holy leaf. They are well defined. Some of these plaques are calcified. And we see also asbestos is present on both lungs. So in this case, it's asbestos related pleural plaques. Then in the third case, we see some lamellar component or congregation is also present. And we also know that on the left side, the left costophrenic angle is obscured due to accumulation of fluid on this area. So all these features are related to a pleural effusion. Then we move to the fourth case, where we notice a decreased opacity in the left dome, which may represent a presence of air or gas in this area, and it's accompanied with sharply defined left heart border. So all these features are related to pneumothorax. And here in the right image, we see enhanced opacity on the left lung, where the left heart border and costophrenic angle and the hemidiaphragm are obscured. And at the top of this white area, there is a concave line which indicates a meniscus sign, and this sign is a marker for pleural effusion. So in that patient, we have pleural effusion on the left lung. Then at the last case, left one, we notice a very clear visceral pleural edge on the left lung, and in the same area we notice the third rib fracture as shown in the small image in yellow shadow. And so all these features are referred to be a pneumothorax, but we should examine if it is tension pneumothorax or not, and this will be by looking if we have any tracheal or mediastinal shifts away from the pneumothorax area. So we go back to the image, and we take a look on the chest x-ray. So we see that there is no displacement of the trachea or mediastinum, which means that there is no tension. So only pneumothorax without tension. And thank you for your attention, and see you on the next video.